Welcome to the Point of Medicine podcast, brought to you by LearnNeuralTherapy.com. Doctors Ann Hill and Alana Gurvich team up to take a deep dive into the art and science of healing. This podcast explores cutting-edge approaches to the autonomic nervous system and its role in organizing fascia for optimal health. Each episode features conversations with leading clinicians who are pushing the boundaries of medicine, uncovering new insights, and transforming patient care. Join us as we bridge tradition and innovation to expand what's possible in modern healing. Just a reminder, this podcast is for educational and entertainment purposes only and not intended as medical advice. Please consult your healthcare provider before making any changes to your healthcare plan. Join us and let's jump into the next episode.
Hey everybody, we are here today with Dr. Robert Banner, and Dr. Banner is a medical doctor in London, in Canada. And I went to visit Dr. Banner and I was hoping I'd be in London, but I was in a different London than I wanted to be in, but it was a very nice trip. So we're excited to be interviewing you today. Let me go ahead and just introduce you, Dr. Banner. You are going to be talking to us today about something we're super interested in, which is IV use of Procaine to address vagal nerve dysfunction and hopefully answer a bunch more of our questions. You are currently in private practice in London, Ontario. You're board certified in family medicine and anesthesiology. And Dr. Banner also holds additional certification in traditional Chinese medicine and acupuncture from the University of Alberta. And he's also a member of a whole bunch of different professional committees and organizations, such as the North American Academy of Neurotherapy. He was a past president there, and he is also a member of the Functional Medicine Practitioners Association and the American and Canadian Academies of Pain Management and the American Board of Integrative and Holistic Medicine. And you're also a member of the American Ozone Therapy Association. And let's see here, you also looks like you got certification in homeopathy, which is really great. At the Centers for Development of Homeopathy. And your main target for your patients is really trying to get to the root cause and understand why they are still ill and trying to do that. So thanks for joining us today, Dr. Banner.
Welcome. You're very welcome. It's good to see you.
Yeah. So first question, Can you tell us how you got interested in, pursuing a career in medicine, and then how you went down the more complementary medical route, and how you got involved in neural therapy?
The start is a long time ago. The start was really someone who encouraged me that I could apply to do medicine, because I didn't think that I could. And in fact, the same year, I was accepted into dentistry and medicine, and I chose medicine. But my process through medicine was rejoining the Air Force in Canada. So I got them to pay for some of my education, and I owed them time back. But the time back was spent at a base where I did diving medicine, hyperbaric medicine, and aviation medicine. So there was exposure to that as well. So it was already getting kind of different. The hyperbaric medicine was really done in conjunction with Misericordia Hospital in Edmonton, and with intensivists that worked there. So it was great to work with him. It was a great experience. Neural therapy was after I got out, and my experience started with Dietrich Klinghardt. And honestly have to say that I was skeptical of what I saw, and I had to try things out for myself, and it worked. And I was always more interested in addressing what was underneath than just treating a symptom. And the neural therapy fits that role very well, and it's something that I think about every day and think of with each patient. So it's something that's useful.
What led you to find Dietrich to look further?
I was interested in the muscle testing that he was doing and the neural therapy that he was doing, and he just happened to put those two together. Admittedly, I'm going to say this nicely, a very smart fellow, puts things together, but doesn't necessarily teach things that well or convey concepts. And I think that's where I got lost, really. And that would have been in the late 80s that I would have done that with him. So it was a combination of both those things. And then the muscle testing was something that just developed over time. And now I use in my own practice with every patient.
Wow. How long have you been practicing neural therapy?
Close to 30 years, I guess.
Wow.
Yeah.
So we really wanted to talk to you a little bit about, I think one of the things you really love to do is the Procaine IVs.
Mm-hmm.
Can you tell us a little bit about how you got into that and where you learned how to do those?
The interesting part is in Canada, in Ontario, if I do injections into ganglia For example, my facility has to be licensed differently and gets inspected every year, and I have to pay a fee every year. So I wanted to, while I was in the hospital, I could do those things. But now that I'm in private practice, not so. So I looked for other ways to address the same issue. And that's where intravenous Procaine came up. Because I could do that, and I could do it easily, and nobody had to inspect my facility. And that is something that I started in a pain clinic in the hospital, and then it's evolved. And I would have to say that probably we do at least 5 or 6 IV Procaine infusions a day in the office. And of course, medicine being what it is in Ontario, there was no fee code for it when I first came here. And there's a fee code for it now because my wife and I submitted that, and it got approved, which was just really bizarre. So people are excited because they can do things that they don't have to pay for. Their taxes pay for it.
So your recipe is 1% Procaine, it's sodium chloride, and it's bicarb? That's the...
It's a 2% Procaine. It's what I use for injections as a local anesthetic. There's nothing added to it. It's preservative-free. It's pH neutral, and it's added to a 100 cc bag of saline. So I would use 2 milligrams per kilogram for women and 5 milligrams per kilogram for men. And the difference between the dose is the fact that increasing the dose concentration in women will increase their side effects, but not the efficacy of what they receive. Whereas men will, if they use less than 5 milligrams per kilogram, will have less efficacy and no side effects. Procaine I use over lidocaine because it's faster, can be administered faster, usually over about 20 minutes, and it's got much fewer side effects than lidocaine does.
And you're not adding bicarb to that mixture?
No.
Huh.
No, just Procaine. But I would have to say that probably just about everybody I see is acidic.
Mm-hmm.
So there may be another way to treat their, the bicarb may be helpful, but a one-time administration is not going to correct the situation for them, I don't think, of them being acidic.
The first person who introduced me to Procaine IVs was Rolf Ottemeyer out of Switzerland.
Yeah. Yeah.
And he was specifically talking when he lectured about the pro clusters, which is the reaction that happens when you mix the Procaine with the bicarb to form this other agent that he thought was medicinal. And you're saying you're getting good efficacy without even adding that in.
Yes. So people come and whether it be a blood pressure issue or heart rate issue, a voice issue or a breathing issue or pain somewhere, it's corrected with the Procaine. And one of the places I would use Procaine also is those who come who have interference fields that are identified in maybe 25 or 30 areas. Lots of, right? So I use the Procaine infusions because that will kind of treat things down to maybe hopefully 3 or 4 that actually need to be treated by injection. The others don't need to be. Ralph actually did a paper with Laura Pinilla, and I've reviewed that paper for publication. So they weren't aware of that, but I was one of the reviewers for their paper. Yeah, it can be super simple. It's just how much do you weigh? Give you this much Procaine, let it go. And it's if they experience side effects during the infusion of local anesthetic, you turn it off or just decrease the infusion rate. I don't use the pump, just a little wheel thing. Yep.
What kind of side effects do you find people have had?
Like with local anesthetics, dizzy, lightheaded, numbness, tingling, ringing in their ears. No one has had a seizure.
Lovely. That's good. Good to know. That's
only happened while I was in the hospital. The person was getting kind of twitchy, and I knew that was going to happen. The anesthesia resident didn't believe me till the patient seized. And then of course they had their seizure and they felt great afterwards, but they never came back. So it's a very safe thing to do. And you feel like patients do best with a series of these, or it can be a one and done? It's one and done. So in Ontario, for whatever reason, because we never set a limit, they've set a limit of 6 per calendar year for the infusions to be paid. And so people are told if your symptoms return, then you should come back. If they don't return, then it's probably solved. There's a variety, some people will come back at different times, and they're of course different people from when you saw them first. And I say that, well, if you do this infusion and your symptoms get better, it was the right thing. And if you don't get better, don't persist with what doesn't work, because it should work. So you have years of injecting in the hospital doing ganglion injections, and now you have years of injecting in the private practice doing IVs. Can you compare and contrast what you're seeing with efficacy? I think they're just as effective, probably more so, in the sense that you're treating things you probably don't even know exist as a problem. And I think that's helpful, because there's things that you probably missed. So from an efficacious point of view, I find both to be injections or infusions to be effective. right?
So do you also do then on the same day, will you do a Procaine IV and an injection, like muscle test to see if there's still an interference field? Or will you have them come back and do that?
They would come back. The reason for that being we would set up initially what would be most important for them to receive that day and proceed with that treatment. And then if there's something left over afterwards, I see them again. Does that make sense?
Mm-hmm. Yeah. So one of the questions we like to ask all of our attendees or guests is if there is an injection that you really like doing on a lot of your patients or feel like is a really important one to do for a lot of your patients.
What's your favorite injection?
Yeah,
As if you could choose just one.
favorite
one that
color,
works.
favorite injection.
So it can be bizarre. It can be something that is completely on the other side of the body, completely unrelated, and actually may be old. So, for example, the most recent would be a lady who is probably in her 70s now. She was in a car accident when she was 20. She almost died. There were other people in the accident that died, and she had a scar on her right ankle, basically from above her ankle to her, almost to her large toe. So we did that this past week for the second time. Of course, she had a return of memories and emotions around that incident, which was good. We just talked through, which you'd expect because the memory is stored in the tissue. And it was just a simple scar injection. She has more range of movement, less pain, less swelling in her foot. I mean, that's a local thing, but it can be something that is on the left leg that's affecting the right shoulder. And avoiding doing ganglion injections because I don't want anybody here to look and see what I do. So if I think that's appropriate for them, I'll often see things that collectively make sense. So let's say someone has a symptom, the ganglia is an issue, the autonomic nervous system is an issue. There's a bunch of things that all line up that all point the same direction. And their autonomic dysfunction may be related to 4 symptoms that they have. I'm just thinking this past week, treating one thing will take care of all of those symptoms. And it often does, which is a surprise to them. They don't understand, but that's okay.
And your practice right now is primarily pain medicine based?
I see anybody who comes in. So whether this is under a year or whether this is into your 90s with whatever complaint you have, I see you. Some people will look specifically for neurotherapy and they'll find me that way, but it may end up being something totally that's different. And of course, they don't always think to tell you everything when they come, in the sense that, I didn't know you could help me with this. Yes, I can. You just have to let me know, right?
So Robert, you have your daughter has she graduated yet? You have
One more year.
another,
One more year.
one more year. So you have an up and coming naturopathic doctor in your family. I'm just curious, is she taking after her dad and wants to learn neural therapy?
She hates needles. She hates needles. For her, it was a stretch to do acupuncture. And we did that a few weeks ago when we were on vacation. She came to join us and we did some cupping, we did some acupuncture. And this past week was her doing stuff for intramuscular injections, which were great to her surprise. And then she has to do IVs next week, I think. So it was a hope that she would kind of take things over, but I don't think that's going to happen. But that's the way it is.
I'm still waiting for one of my kids to decide to become a physician too. We'll see.
It was for me, this was something that you should always do, right? I always said, if you go into do medicine, this is a core path you should take. Don't take other paths because you'll find them limiting. And you'll find that when you get to the end, you have to actually relearn things that actually work, right?
Is she in one of the Canadian schools or is she in a US school?
Yep. Canadian. Bastyr. Well, which is now CCNM because they joined.
Right. Boucher.
Yep. Boucher.
Yep. Yeah.
Boucher.
Did they join Bastyr?
No.
I said Bastyr, but it's Boucher. I was wrong.
Okay. The other B. Okay, great.
Yeah.
And so you use Procaine IVs. What are other tools that you pair with for patient treatments that you find effective? Or how do you choose what to do?
So I give the patient the choice of what they want to do. I explain what I see and I give them options. And some people are more comfortable with injections, with prolozone injections, with using ozone. Some people are more comfortable with homeopathy. Some people are more comfortable with supplements. Kind of depends what they are most comfortable with, right? Yeah.
And so what are tools that you're often repeatedly pulling on?
Homeopathy
Homeopathy a lot?
and supplements a lot. Yeah.
So, can you tell us right now what is sort of what is inspiring you most about medicine at this moment? Trying to be positive about the future.
I'm looking for that actually.
Okay. All right. Yeah.
Honestly, it's people come, they get better, they leave, they feel better, they're surprised. That used to be exciting and rewarding. Now it's kind of almost an expectation. Like if I don't meet that expectation and you don't feel better, then I'm missing something. And I try to figure out what it is. Sometimes I'll go outside the room and I'll come back in like, I've never seen you before. So tell me from the top, because if I listen to what you have to say, you'll probably tell me what the answer is. There'll be something that kind of trips off in my mind.
Was it a transition? Because you practiced in the conventional medical
Yeah.
system for a long time. Was it a huge transition moving out of it, or how did you transition in the alternative medicine knowledge that you were learning into the conventional system, and then what finally made you decide to not be part of the conventional system?
Not being part of the conventional system was not by choice, not my choice. So in 2000, I became part of what I did. So I would do my own practice, but I would do anesthesia part-time in the hospital. And then the anesthesia in the hospital became doing anesthesia in the community. And then COVID came and things changed yet again. I'm against things that don't treat the reason why you have the problem. And unfortunately now it seems the last place people want to go is a hospital, because when they go to a hospital, unless they have somebody to advocate for them, they'll eat poorly, they'll have their supplements taken away that actually work for them. They'll have things done that they don't need to be done, things that are confusing. So I think one of the things I do now is I look for a D-dimer, an antinuclear antibody, and kidney function and cancer in every patient.
What are you looking for? Tell us why. Why the D-dimer? Why, what cancer markers? Why are you using those?
Those are something that all came along with an injection
Huh?
for COVID-19.
Oh, I see what you're saying.
So autoimmune disease, common. LVD dimers, common. Cancers, common. Unfortunately, almost every day I'm seeing that now. So with muscle testing, it would show up as an increased opening angle, which would be also called an excessive yin state, that if you allow it to proceed long enough will develop into something that you don't want to be there. And so whether this is brain or lung or colon or wherever, it shows up. Some people don't want to know, but what's been useful for that has been the mushrooms, for me anyway.
Medical mushrooms or hallucinogenic mushrooms.
Medical mushrooms.
We're in Oregon, so hallucinogenic mushrooms would be the answer.
Do you do any other like conventional testing for cancer, or is it mostly like you're trying to find if the signature's in the body with your muscle testing?
I have to be careful and say that I don't treat cancers. And honestly, there's not a single oncologist who's ever wanted to talk to me about anything. And oftentimes it puts the patient in a very awkward place where they have to go to see someone for a certain part of their care, and they don't tell them about what the rest of what they're doing is. And doing that actually risks you losing your license to practice. And I had one patient who went, and the physician wants the file of the patient. They get it every time they come. So they get a sheet that's printed out for them every time about what the visit was. But she doesn't want her family doctor to have that. So just before I left on holidays, I got a note from the oncologist again requesting the same. And I had to write a very humble pie kind of letter back. What do you do? The patient says, no, I don't want to do that. I don't do that.
It is, well, at least in the US, it is their medical record for sure.
Mm-hmm.
Yeah.
Yeah.
Yeah, I kind of do the same. Like I always tell people I don't treat cancer, but I do treat the immune system. And I'm trying to look for areas in the body where the immune system is not functioning well.
Mm-hmm.
Do you have any, like with treatments, do you have anything like just in terms of looking at the immune system that you feel has been really helpful besides mushrooms
And muscle testing?
and muscle testing and neural therapy?
And neurotherapy. If there's an organ or a system that needs support, I'll try to support that. So if it's the liver, we'll support that, right? If it's something else, we'll support that. People come in having obtained elsewhere ivermectin, fenbendazole, mebendazole, other things, and they want to know either do I need them or what's the dose? Am I using enough? I think the book that was published by Dr. Merrick from FLCCC on cancer is very useful in terms of what evidence is there. Some people really like to see that. So in Canada, still, you can't purchase the book. Amazon won't let you purchase it. So I had to track down a used copy and that I actually got from the United States. So people like to look at that and see. So one of the people that would fit that category. So here's a very bright lady who had a master's in biochemistry, who went on to do veterinary medicine, who 5 times, I think, she was going to write her exams, but they were canceled. And then she was going to do a fellowship in Kentucky for large animals. But of course, she couldn't cross the border unless she was vaccinated. So she got vaccinated, and then she got myocarditis, pericarditis kind of thing. So she's been dealing with those issues ever since. She loved that book when she looked at it, and she's on colchicine. Why is she on colchicine? Because of its anti-inflammatory effects. But anyway, digressing. She's someone who did neural therapy before as well, right? And as a veterinarian, because she's seen an improvement with her mom and she's seeing improvement herself, I'm trying to connect her up with another veterinarian locally who's got kind of the same mindset as her. I think it would be awesome to work with animals to provide that service, to think of it.
To do neural therapy or to help with oncology?
To do neural therapy, just to be open-minded about when you see this animal, the animal may reflect what's going on with the owner. You never know, right?
I definitely see that a lot. People
Often it is.
who are really sick and they tell me, oh yeah, my dog has cancer, or I'm like, oh, okay, there's something going on there.
Anne actually talks about that in our neurotherapy trainings, and talks about how oftentimes you'll see these constellations of, parents, children, animals, all presenting with the same constellation. She's like, that's one of the ways, she talks about how that's one of the ways in to her chronically ill patients is through that lens.
Yeah, especially when you can't get a good enough story from one of them, then you're like, oh, okay, I got the story of the dog and the kids, so now we know.
Now we know.
Yeah.
So Robert, so that's, neural therapy is not at all recognized in Canada, right? What's the state of neural therapy in Canada? Okay, so that's kind of a huge thing that you were able to petition the Ontario/Canadian government to recognize Procaine IVs or anesthetic IVs.
Would you like the backstory a little bit?
Yes, I would love the backstory. It's very inspiring.
At the time, there was a group commercially that liked to do IVs for people. And I think that the reason it was approved was because it really came through that group. I don't think me saying that BC does it or Alberta does it and has a fee code for it, I don't think that's enough for physicians here to do it, and not enough to go to the Ontario Medical Association, who's only going to get a big piece of the pie, right? To say, okay, well, we'll give up some piece of this so we can fit in the neural therapy because the pie is only so big. So I was surprised to see that. And it was my boss, the pain clinic director, who was supposed to make the submission, but 2 days before, she had never made a submission. So people did it, but they would bill fraudulently for it. They would call it something else. And in fact, when I came to London, they said, do you do intravenous local anesthetics? And they would laugh. And when I said yes, just like, so you learn.
Yeah.
But yeah, so I'd like people to know that, one, you need to think about it or you're never going to diagnose it. And two, when I see the POTS syndromes that have evolved in a bunch of people, and I see other things, it makes you should consider, even if you don't understand, you should consider something that's very safe and very simple to do.
So you are seeing efficacy for the postural orthostatic tachycardia syndrome presentations, the POTS symptoms, and you think that efficacy or that improvement in symptoms is coming from the Procaine, not the sodium chloride? Because the treatment for POTS is also to just get lots of sodium chloride in them.
They don't get enough.
Yeah, that's what it does not sound like they get enough with 100 cc's. What are you seeing? Can you give us a patient case?
I'm trying to think. Because they don't just have isolated POTS, they have other things that go with it.
For sure.
And sometimes they don't tell you. And sometimes you end up seeing them for months before they actually say, well, I've got this, right? Or it's something, the way they're dressed just kind of draws your attention to something, that looks kind of strange. So you follow it. And for the POTS, I would say get that veterinarian is probably a good example of that. She has autonomic dysfunction. And is that part of, when we talk about the vagal stuff, is that part of the body even if the mind doesn't recognize it, the body recognizing there's threat or danger, and then upsetting things for them, which are expressed different ways. Heart rate changes, or blood pressure changes, or body temperature changes, or sweating, or swelling, or whatever it might be. He's actually a patient for whom IV Procaine would be helpful, but she's reluctant to do it because she's done it once, and she had almost took 4 hours to get through the infusion.
Oh, that's a long time.
That's a very long time.
Yeah.
And so I go, okay, that's fine. You don't want to do that. Let's see if we can find something else. And they usually find a herb or something like a horse chestnut or a hawthorn or something to replace that, which often makes sense because they will often have an emotional heart issue. For example, with hawthorn or horse chestnut, I think it's because they're afraid of something, or their body senses that fear. And I would be afraid too if I got chest pain, if I had my heart racing, if my blood pressure was all wonky no matter what I did. If I bent over, I would have these symptoms, And she's single and she's on her own, and this is what she's able to do, So there's some restrictions for her as well. She's given up her job that she had, and she's working somewhere else now, part-time and fewer hours, and she's almost without symptoms. But yet that autonomic dysfunction is there. So I think it's deeper than the vagal nerve. And so I'm reading this book called Deep Brain Reorienting. And I think it's deeper than that. I think it's expressed in that system, but I think the reaction happens deeper with what they see or what they hear or something that sets it off. Yeah.
Yeah, I think it's really, I had a whole conversation with another provider at a conference I was at recently, and she said that her daughter has POTS and MCAS and all that, and that she's actually doing a deep dive into glial cells. And I'm like, yeah, we didn't even know, we still don't even know what glial cells really do, And that so I feel like there's so much that we still don't understand about how the whole nervous system works together. And we talk a lot about vagal nerve.
Yep.
That's what we know the most about, but I'm sure all these other players are things that we have yet to really discover how they have a part in things.
Yeah, it was only until just recently that we stopped calling them brain helper cells.
Yeah.
Yes.
Like that's a very recent phenomenon.
Oh, totally.
Yeah. Yeah. And do you have any good stories about using Procaine AV in POTS?
I'll tell you what, it's interesting to me because, I do a lot of stuff with long COVID and with patients who have POTS and mast cell. And I'm a little leery of using it if they have a larger mast cell presentation. So because I feel like Procaine helps the whole body detoxify. And if the mast cells are already super annoyed, I don't want to put them in a flare state of any point. So I don't know if I've used it specifically just for POTS, but I have definitely used it sort of in my mast cell POTS long COVID population after I've got them on kind of a more like a detox protocol and on mast cell stabilizing medications. And then it's been super helpful. Like it's actually been really nice because a lot of my patients who have already done kind of some of that work, then like we actually get to the good stuff, which is a lot of the mental emotional release. And getting to some of the scars where they have, a lot of emotions tied into those. Yeah, I almost feel like that's like, it's just really nice because they can just automatically go to those sort of deeper levels of things. So, yeah.
So let me just translate what I'm hearing you saying. What I'm hearing you saying is you feel with that, POTS plus, so the MCAS POTS population, the first thing you're going to do is stabilize their mast cells and kind of try to get them on some of the pharmaceuticals and the binders and the detox. And once you feel like they're stable, then you'll be able to pull in the Procaine IVs. And those Procaine IVs seem to be helpful to help them keep on processing deeper patterns. But you're a little bit afraid to touch those patients with Procaine IVs or even Procaine in general until they're stabilized with their MCAS.
I am, but I mean, I also, honestly, I'm seeing patients that are like, they can eat like 2 or 3 foods. And, if they look at something funny, they'll have a mast cell flare,
Yep.
They're very, very sensitive patients when they get to that point. So
Procaine is a mast cell stabilizer, so it makes sense. But at the same time, the patient that you see is only going to be able to tolerate so much.
Yeah.
Right. And if you're too aggressive, you exceed their capacity to be able to deal with it, even if it's the right thing. And I think that's it.
Yeah, I agree. It's a mast cell stabilizer, but I think it's the detox part of it that is what is flaring, what is going to put them into potentially a flare.
Mm-hmm. Mm-hmm.
So yeah. But I think it's an important piece of things because all the mast cells are hanging out in the connective tissue, and that is exactly where Procaine works. And all of the mast cells connect to every single nerve ending in the body. So if we're treating the nerves, we're treating the mast cells, which is great. Cool. All right, little pots diverging there. So, do you have any other questions, Alana?
No, this is just, for me, it's exciting to hear a different Procaine IV recipe than what I've been taught. And I can't wait actually to jump into the clinic and start seeing where it lands me. It's such a useful tool. And the Pro clusters, I was pulling on Procaine IVs a lot more when I had like the most complicated patients and didn't know where to start, or when I had somebody with a crazy hyper vigilant, hyper emotional nervous system. And I was looking to reset them, like go into all their nooks and crannies and reset their nervous system. And I had some efficacy with Procaine IVs for that. So I'm excited to try something different.
The protocol is set out by the fellow that you're referring to, Laura Pania. I thought that was complicated. I thought I think they suggested at least 5, and they had a whole protocol to go through. The protocols miss the business of people being individuals and unique every time that you see them, right? So, I mean, I may have seen you a week ago, but you're a different person today. Or your blood work showed this, but that was done a month ago. So that doesn't reflect who you are now. That's why we can see things that are different now that don't necessarily agree with your blood work. And people have a hard time getting their mind around that. And I think this is an advantage of neural therapy in the sense that you're thinking about, it makes you think about the individual, makes you think about the person, and listen to them. Yeah.
Robert, where can people find you? Do you have a website?
I've got a website. Yep.
Uh-huh.
Yep.
What is it?
Let's see. I got my cards right in front of me. It's Dr. Robert Banner.
That seems pretty easy.
It seems very
easy. Yep. Yeah. I have to be careful with what I put on the website.
Yeah, we all do. Yeah, we all do. Well, thank you so much for your time. Our listeners don't know it was a little bit of a dramatic getting everybody in the same room for the recording, but we succeeded. And so I just really want to appreciate you being able to talk about what you do. And because that, I feel like the way we're going to teach people this amazing tool is just to be talking about it more and more. So thank you so much for your time. Thanks for joining us.
Thank you.
Thanks for joining us today. If you like the episode, please like and subscribe to our channel and review us on your podcast players. Also, if you think this episode is helpful to some of your friends or colleagues, please share it widely. If you are curious about learning about neural therapy or other injection techniques, check out our courses on learnneuraltherapy.com. We'll see you next month for our next installment of the Point of Medicine podcast.